Good evening, everyone, and welcome. This is very exciting tonight for us. Thank you for joining us tonight for the Dr. Roger Bland Lecture Series on Improving Children's Mental Health. This lecture series is presented by CASA, Child, Adolescent, and Family Mental Health, and our many partners, the Institute of Health Economics, the University of Alberta, Department of Psychiatry, the Edmonton Public School Board, and the Alberta Alliance on Mental Illness and Mental Health. We are super excited about being in the center tonight, and we hope this is our future for the community lecture series. We think it's a fabulous venue. As you know, it is our goal that the Dr. Roger Bland Lecture Series is here to inspire hope and wisdom through the expertise of our keynote speakers and panel members, and to engage you, the audience, in conversation and learning. We want to create a meaningful conversation of change by talking and providing information that we believe is helpful to you. Tonight will be an informed and candid conversation on fetal alcohol spectrum disorder and its effects on the mental health of our children and youth. FASD, as you know, can have a broad range of effects on those who are exposed to alcohol prenatally, and these effects have a lifelong implication for the individual and their families. Tonight, we will discuss the current research and how we can best use these findings in children's mental health and in the community to best support the mental health of those suspected or diagnosed with FASD. I would now like to introduce to you our moderator, Leslie McDonald. Leslie is well known in our community through her work with Global TV, her active involvement in community initiatives, and her communications company. Please give a warm welcome to Leslie.
Hey, thank you. Thank you, Denise. I'd like to begin by acknowledging that we are on Treaty 6 territory, a traditional meeting grounds, gathering place, and traveling route for the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. So isn't this a cool venue? This is our 6th in the series of lectures, our first time actually in this theater. And there's one thing actually, well, two things that I ask of you. First of all, just make sure that your cell phone isn't turned on or the volume is turned right down. And the second thing is, this is designed, these seats are designed for you to be able to lean back and look at the stars in the sky, and please don't fall asleep on us. So, this is, it's going to be a very interesting evening. We have quite a dynamic group. For those of you who've been part of this before, you know that we begin with our expert, our keynote speaker, to sort of set the lay of the land and give us the groundwork. And then we have our own panel of experts, and we have a discussion, and then we will eventually get you involved in the discussion as well with your questions. As Denise mentioned, our topic this evening is Fetal Alcohol Spectrum Disorder, or FASD, and we are so pleased to have Dr. Jacqueline Pei as our keynote. Dr. Pei is an associate professor in the Department of Educational Psychology at the University of Alberta. She's also assistant clinical professor in the Department of Pediatrics, and she still practices, which blows me away, as a registered psychologist. Dr. Pei's interest in FASD began in her first career working with incarcerated youth as a criminologist and forensic counselor. When she saw and learned, and what she saw and learned motivated her to return to academia to study youth at risk, child development, and neuropsychology. And that led to her current focus on interventions for individuals with fetal alcohol spectrum disorders. Dr. Pei has worked on FASD diagnostic teams around Alberta, has authored 75 publications on the subject, and maintains a small practice where she integrates psychological assessment with meaningful interventions. She also leads the Intervention Network Action Team for the Canada FASD Research Network, and she works as the National Network's Senior Research Lead. Her passion is to facilitate the transfer of research to practice to policy initiatives that supply and support healthy outcomes for children and adolescents. Dr. Pei is also a mother of 3, and she says that keeps her focused on what's really important in life. So please join me in giving a warm welcome to Dr. Jacqueline Pei.
Thank you. Okay. Thank you so much for having me here this evening. This is such a different venue to present, and I'm not really sure where to look. My voice is kind of echoing back at me in weird ways, so bear with me, and we'll see how we make this work. I'm really excited about the format as well. I'm introduced as an expert, and really I think that I have the luxury of working with the true experts in the field, and you're going to hear from those guys soon, and I think that's going to give us an opportunity to really turn this into a meaningful conversation. For now, my goal for the next 30 to 40 minutes, anyone that knows me knows that talking for 30 to 40 minutes only is a really difficult task. So I have a little timer here that I'm going to keep looking at. What I want to try to accomplish over the next little bit is to introduce us all to FASD, just so that we're all on the same page. Then we're going to talk about mental health, and then we're going to move into talking about intervention and next steps a little bit. So those are the things that we're going to just talk about at a fairly high level, and then hopefully we can turn that into a meaningful conversation as we go forward. It's here saying, yeah, I'm already pretty much an expert. Okay, I know something. Can I do that better? Okay, we got a few hands. All right, so I figure what we'll do to have a little fun with this as we get started is we're going to have a bit of a quiz. So you're going to have to put it all out on the line tonight. It's not just me in the spotlight, although you guys are kind of dark, so you can kind of hide a little bit. Yeah, I'm watching you. So here we go. This is the test for the evening. First of all, I'm going to ask you what FASD is. These are the long, kind of boring definitions up here, but there are 3 different definitions. The first one says that FASD is cognitive, emotional, and behavioral deficits following prenatal alcohol exposure. The second one adds in physical to that list. And the third one says it's a physical disability due to prenatal alcohol exposure. Okay, who here votes for A? Wave your hands around. Okay, we got a little bit of hands, a few tentative, I like that. People are like hesitantly putting it up. Who says B? Oh, look at that. How about C? A little bit, maybe? Nope, hesitant, hands go down really quick. I love that. The answer here, B. It is all of the above. What's really interesting is as we've begun to understand what FASD is all about, in the very early days, it was first identified for physical differences. That's how we first knew FASD back in the 70s existed. Then we kind of forgot about a lot of the physical pieces, and we started talking a lot about the brain-based differences and how FASD is all about brain-based differences. And now recently, in the last 5 years or so, we've started to say, guess what? This is actually a whole body disorder in which the way that people think about information, socially interact, behave on a day-to-day basis, and physically experience the world, be it how they move, their susceptibility to disease, things like diabetes, cancer, arthritis, are all different for the population. So they're very vulnerable in all of these areas. So the answer there is B. Bing, bing, bing. Okay, next one. Now that you're all feeling kind of warmed up and confident. In pregnancy, A, moderate alcohol use is safe. B, alcohol consumption is safe in the last trimester. Or C, there's no known safe amount of alcohol at any time in pregnancy. Who votes for A? Watching? Everyone's hiding now on me. How about B? Any takers? C? Whoa, we've got a shared opinion here. We got a wise crowd with us tonight. You guys seeing all this? Yeah, okay. I feel like I'm done. I can just leave now. It's all over. But you guys are absolutely right. The answer is C. There's no known safe amount of alcohol in pregnancy. And this is something that we've taken a while to get here, and there's been a lot of discussion as to whether or not there's a safe level of alcohol. And the conclusion now is that definitively there's no safe time, no safe amount of alcohol, and the Canadian Medical Association speaks to the importance of us supporting healthy pregnancy within communities. What does it mean to help women to experience a healthy pregnancy can have the healthiest babies possible. And that's the supportive perspective. The other comment that's been made around alcohol is that alcohol is really an equal opportunity teratogen. What that means is, teratogen is our fancy scientific word that refers to any agent or substance that can cross the placental barrier, so can get past the defenses, and has a toxic effect on a developing baby. Anything that does those two things, gets past the defenses and is toxic, we call a teratogen. Alcohol is a very well-established teratogen. And if I can get that up right, yeah, getting there. It's been a long day. I'm working on it. Thanks. Yeah, so equal opportunity teratogen, and it affects anyone who consumes alcohol. It is not anything that targets specific groups or specific vulnerabilities. It is an equal opportunity. We do know that FASD occurs in the context of social determinants of health wherever alcohol is used. More vulnerable or marginalized populations may see higher rates as a reflection of that marginalization or vulnerability, which relates to alcohol use. It's the alcohol use patterns that are the important ones to look at and to notice. FASD has historically been a highly stigmatizing condition. It's something where it's very easy to judge and begin to feel defensiveness or uncertainty in talking about it. Biological moms often feel a tremendous amount of vulnerability when they're asked questions about prenatal alcohol use and feel as though they're going to face judgment or blame. Consequently, we've said it's really critical to approach conversations about FASD from a very supportive approach, thinking about what it means to not only promote a healthy pregnancy, but create healthy communities for all women, all couples, all families. And if we come from that perspective, then we create the opportunity for conversations that are open and honest, supportive, as opposed to shaming and blaming. Okay, ready for the next one? We're all good to go? FASD is relatively rare, affecting less than 1% of Canadians. True or false? Who says true? Okay, got a little bit of truth out there. Who says false? That's kind of the rest of you. Yeah, it's really the way it goes. It's actually false. The accepted Canadian prevalence right now is 4%. And in fact, that's considered a fairly conservative estimate because we're still working towards a truly reflective diagnostic capacity. So we're still catching up in terms of diagnosis. So 4% is conservative, and yet 4% is a rate that's higher than any other developmental disability out there. So autism, by comparison, is about 1.5%. Oh, that was close. Oh, yeah. Give me time, I'm going to keep pacing back and forth. I'm going to have to walk behind the podium to be safe. This is my support crew over there. They're supposed to keep me from falling over. The numbers in different studies vary around the world, and there's a fair bit of national variation in terms of what the proportion is reported at. But as I said, in Canada right now, we have an accepted rate of 4%. So really high. This is a significant problem. If you don't think it's in your community, you're not looking close enough. It's there. It really is. And this is a problem that we need to all be looking at, thinking about, and responding to in that supportive fashion. True or false? FASD can be diagnosed using a blood test. Who says true? False? I feel as though my questions are too easy tonight for this crowd. Right on, you guys. I mean, don't we wish it were true? It's not. Instead, we see that FASD is diagnosed through a multidisciplinary team. It's a complex diagnosis where a lot of factors have to be taken into consideration. Many different countries provide different approaches to the diagnosis, but across all countries throughout the world, we all agree that a multidisciplinary team is required. We need a lot of different people considering what the unique impacts to the brain and body of the individual are in order to understand not only that there needs to be a diagnosis, but what the implications are for the individual who is affected. When we look at diagnosis, we look at multiple areas of brain function. You see a whole whack of them up there. I'm not going to go through them all for us today, but I want you to see how much is covered, how much variation there is there, and the fact that to get a diagnosis, an individual has to have evidence of a severe impairment in at least 3 of those areas. 3. So when we're talking about 4% of the population has FASD, we're not talking mild, a little, or small impairment. We're talking significant impairment in at least 3 areas of functioning that affect their ability to be successful on a day-to-day basis. That's a significant number, and we have a very conservative diagnostic criteria. We ask for there to be a really substantial amount of difficulty before we make that diagnosis with any kind of certainty. This is a group that really needs our support. The other thing worth noting is that when we're talking about brain, we don't always see that an individual is affected. In fact, only about 10% of individuals diagnosed with FASD present with any kind of physical features that may indicate that they have this. The majority of individuals with FASD present with an invisible disability. We don't realize it. We don't see it, and in fact, it may not even present in certain areas of typical testing. So it's easily masked. So they have significant brain and body impairment that is unique to each individual and may be invisible and not readily identified. This creates some conditions for risk. If we don't know it's there, we don't always respond appropriately, and we create a disconnect between the services and the individual. When we recognize that an individual has a need, that their functioning behavior is not a reflection of their choice or their desire to make your life difficult, but rather a reflection of a brain-based difficulty, we put ourselves in a position where we can make a meaningful diagnosis that then leads to FASD-informed supports that in our research and in our practice, and you'll hear about it, can have significant impacts on outcomes for these individuals. When we identify the population, we can see really positive things happen, and there are some really great success stories for individuals with FASD. It's not just one dark pathway. All right, I think we're on our last question. Everyone ready? This one's kind of a tricky one. Maybe I had ended with the hard one. FASD is a permanent brain injury. True or false? Who says true? Who says false? The answer is false, sort of. Oh, that doesn't make sense. Well, I'm kind of playing with the word a little bit. We knew this would happen. Yes, FASD is a lifespan disability. We aren't looking, when we're talking about intervention and support, we're not talking about curing or fixing a brain. However, FASD does not mean that we're dealing with a fixed state brain. Like any brain, an individual with FASD has a brain that can change, grow, and develop with the right intervention supports. So permanent in the sense that it's lifespan, yes, but not in the sense that we're dealing with something that is unchangeable or fixed. If we're not seeing change, if we're not seeing growth in the individuals we're working with, it's usually a reflection of us having not found the right fit, the right support, or the right intervention to create those conditions that facilitate change. So that's kind of the sort of tricky side to that one. So you all feel kind of like you're FASD experts? I feel like everybody kind of was already. Yeah, sort of. Nods. So we're going to talk a little bit about the mental health side and very briefly introduce some of the information that we know about mental health specifically as it applies to FASD. This is a topic that we could go on at great lengths too. So like I said, it'll be a bit superficial, but we're going to have the opportunity to listen to some real experts shortly. For individuals with FASD, approximately 90% also have mental health issues. 90. That's a really big number. 9 out of 10. In addition, 50 to 70%, depending on where you're looking at the numbers, also present with substance use challenges. That's also a very high number. Those are significant numbers that mean the minute we're talking about mental health, we need to be talking about FASD and vice versa. What kind of mental health issues do we see, or what do we see coexisting? We use the word comorbidity. What we're talking about is things that coexist with FASD, exist also. There are a wide range. Attention deficit hyperactivity is most commonly identified as coexisting, but it is by no means the only one. We see a lot of trauma-related disorders, anxiety disorders, depression, high rates of suicide, sleep disorders, which are somewhat related to mental health disorders, so that's why I kept it in there. As I've already mentioned, addictions. What's not up there is that we also see higher rates of psychosis and other acute psychiatric conditions that require inpatient services. So this is a population that is confronted with a high level of coexisting mental health issues. The question's arisen over the years, why is that? And originally we kind of thought the sole reason for this coexistence is because we aren't providing really good services. So because we're not meeting the needs of this population, they're developing mental health issues, that poor fit between the community and the individual. Still a factor, we think that's still relevant, but we've learned that it also reflects some of the unique effects of prenatal alcohol exposure, as well as multiple other factors that contribute to an individual's presentation. It's complex. There's nothing straightforward about it. We know that there are high rates of pre- and postnatal adversity with the population that also contribute to these high rates and make it difficult. We see a lot of other teratogenic exposure, means there's a lot of other drugs that these individuals may have been exposed to in utero, which make it difficult to understand what you're seeing. Exposure to stress and violence in utero, poor prenatal health care or maternal nutrition status changes the way the baby is able to develop. Both pre- and post-term birth complications are all elevated for this population. So all of those prenatal risk factors are elevated for individuals with FASD. Those all elevate the likelihood of the development of any kind of mental health condition. These are all associated with mental health risks. Then we also see higher rates of adversity postnatally. So as these kids are growing up, 86% in some rates have had some contact with children's services or foster care. 86. That's really high. That is a local number as well. 56% have experienced some kind of abuse, 57% neglect, 20% trouble with the law, 20% substance abuse. These are our littles with the 20%. As you saw from the other number, it goes up when they get older. These are high numbers. These absolutely elevate the risk for mental health concern and mental health issues. But again, this isn't the sole answer. So we have the prenatal alcohol and the birth risks. We have adversity risks, but we also see multiple other risks associated with this population, and they all intersect to elevate risk. Genetics. We're increasingly understanding the role of genetics and the fact that we inherit vulnerabilities to mental health issues such as depression, anxiety, and so on. So you're pre-wired for an inherited vulnerability. Then you have a prenatal birth environment that creates a vulnerability, and then a postnatal environment that aggravates that. The prenatal effects on the brain, the changes to the way the brain functions, affects our stress response system. That's an ability to manage stresses that you experience in your life. This is a population that is more triggered by stress in their life and less able to manage any kind of pressure or frustration that they might experience. So they're kind of wired up from birth to be more vulnerable to stress. And then if we go back, we look at how much stress they experience. So we take a group with more vulnerability genetically and brain-based, and then we expose them to more stress. My math tells me that that's not good. Cognitive capacities are affected. Things like my ability to inhibit behavior, shape or manage my behavior, problem solve. Those will create more frustrations and tensions in my environment. I'm going to have difficulty having success in my day-to-day functioning. Consequently, I'm not going to feel very good about myself. This affects my mental health. Social vulnerabilities, my ability to interact effectively with other folks, my ability to build relationships and friendships that are meaningful is compromised in some cases due to prenatal alcohol exposure, and certainly not helped by the environmental experiences that I've had and the traumas I might have experienced, which is that last environmental piece, which seems to aggravate all of the pre-existing brain-based and genetic vulnerabilities. Consequently, we have convergence of genetic, environmental, and neurophysiological factors which produce a complex picture of vulnerability and these elevated rates of mental health needs for this population. Consequently, it's not surprising that those individuals who have looked at inpatient settings and said, if we go to psychiatric inpatient settings, do we see individuals with FASD more frequently? The answer is yes. And in fact, studies that have been conducted where they've gone into youth inpatient psychiatric facilities and said, let's do a diagnosis, and they're identifying 25, 26% of the youth in those facilities as having FASD, based on that very conservative diagnostic process. These are really high numbers, and these are kids with severe enough psychiatric presentation that they require inpatient service. These are high numbers. This is a really relevant issue. Interestingly, while we acknowledge the fact that there are very high numbers in our psychiatric care facilities, for instance, very, very high numbers in our community population, when we talk about 90%, and a really important need to diagnose and identify the population in order to provide FASD-informed supports. And yet, when we start to study the clinicians, and here I'm kind of looking in a mirror when I tell this story, and we talk to people like psychiatrists or psychologists, the majority tell us that in some way they do not feel that they are equipped to identify and help support diagnosis and recognition of this population. So we have a really high need, and we do not have a well-prepared clinical group. And I've been told that social workers are in the same boots. Yeah, I'm getting a nod over it. We talked about this before today, and I was told social workers are struggling as well. So our clinical group that are intended to be providing that FASD-informed response are not trained and are telling us that they don't feel prepared. This is a limitation to our system, and it's a limitation and a gap that we need to begin filling, and we can only do so in a community. So in terms of interventions and next steps, what do we know? What have we learned? What have we found out? And how are we doing? The good news is there's been some research on intervention that has told us that we can have an effective impact. We can see change, we can experience success, and we can improve outcomes for individuals with FASD. This is kind of when we were talking about the permanence part. We know this is not a fixed state. Our numbers don't have to remain those numbers. We can become more proactive and more responsive to the needs of this population, and consequently we can improve the outcomes. A number of studies have been done, and a number of different projects are identified here, all of which have spoken to the kinds of impacts we can see when we work directly with individuals with FASD. We can co-create strategies that are meaningful and impactful. We can help individuals learn to regulate their emotional states in ways that are effective, useful, and reduce the kinds of outbursts and difficulties they might experience on a day-to-day basis. We can engage in parent-child psychotherapy that helps to support the attachment bond between parent and child in a way that facilitates healthier relationships, better boundaries, and overall better regulatory control. Project Step Up is a really interesting one that's been done. Mary O'Connor did some work down in the States where she worked in an addictions program for individuals with FASD. Within that program, she found that when she works with the family and the youth to co-create some plans going forward that respond to the unique needs of each unique brain, they're able to see some really improved outcomes even when they're dealing with significant addictions. Working with existing supports, we've also seen some real success. So we don't need programs to be specific to FASD all the time. what we need is the clinicians and the folks working within the programs to have sufficient education to adapt their service delivery to meet the needs of the population. When we've done that, we've seen improved outcomes for individuals with FASD when we recognize the unique needs that they have within mental health service delivery. We also know within mental health interventions that we need to be able to support the community around the individual. So we target some things directly at the individual with FASD, but we also need to support the community who surrounds that individual. Like anyone, we all need community, we all need supports around us. Individuals with FASD are no different. When we support healthy families, when we help build parenting capacity, we see improved outcomes for both the parents and the kids. We see reduced burnout. We don't see stress going to the same place. Sure, we're going to hear a little bit about the importance of these kinds of supports to families, right? Yeah. You guys are going to hear that from the experts soon. Really important. If we don't take care of our caregivers, we're done before we start. Supporting meaningful understandings has been an area of increasing research and really impactful research, where we start to look at how we shift attributions or the way we understand the behavior we're seeing in order to shift the way we respond. So if I make sense of behavior differently, then I use a different strategy to respond to you. I don't get so angry with you because I don't take it personally anymore. I understand that this is your brain doing business differently. Changes how I feel about you, changes how you feel about you, the entire outcome. Sort of the ingredients are different. Relational approaches are probably one of the most researched areas of intervention with this population and consistently produce really good results, whether it's prevention initiatives or support initiatives, and particularly when related to mental health outcomes, we see really great work done. Anything mentoring programs, you might hear a little bit of those kind of as well later on, because we have some great mentoring programs in our community. Anything that looks at maintaining stability within a placement and transitional supports, planning supports are critical. We know that placement stability, like any of us, we like to be rooted, we like to have our relationships stable, we like things to be permanent and long-term. This population, that's exactly the same, and in fact, if anything, it's more important. The impact of supports is that much greater and that much more powerful. A couple of colleagues of mine who are amazing and do the work in systematic mental health have come up with their top 10 things they think that we need to have as a part of any mental health strategy in supporting individuals with FASD. And they built a really pretty picture for you at the end. And I will also let you know the website you can go find it at if you want to get it yourself. So the top 10, they talk about we need to shift to proactive services, not just crisis intervention. They put this list together, by the way, based on interviewing a number of professionals, families, individuals with FASD, and frontline service providers across Canada. So by working with all of these folks, they've generated this list based on the information they were provided. Have a support worker assigned to facilitate attendance at intake and through duration of any of the services provided. Recognize that attendance can sometimes be a barrier for our population, and instead of responding in a punitive way, we go proactively and work in a supportive way. Access to programs is essential for individuals with FASD. They should never be excluded based on their FASD diagnosis. An FASD diagnosis does not mean you cannot benefit from a service provided. It simply means that an informed and maybe adaptive approach to the service delivery is required. A mental health professional or addiction specialist should be a member of any youth diagnostic teams. So they're looking towards the incorporation of these experts within a diagnosis so that from that point of an informed understanding, we can build a meaningful roadmap for a given individual. Having an invested advocate is critical to navigation of a mental health or addiction system. Advocacy is identified as just a really important factor, and even how we support individuals in being meaningful advocates, how we work with families and support the process of advocacy is really important. Ooh, I'm flipping too fast now. That was pretty exciting. Primary health care is essential for mental health and addictions. This means having a consistent physician. We find this is a barrier for a lot of our clients who will often get Medi-Center treatment, and so there's never a consistent pattern of care provided. What does it mean to change that and have a consistent physician involved? Mental health addictions component for any support plan should always be a proactive consideration. Don't wait until there's a problem before you have a proactive plan in place. Informing the clinicians, psychiatrists, anyone who's working with the individual, training is a really big part of any service delivery. If you don't understand FASD, you're going to have a hard time delivering services to the population. Number 2 is a favorite of mine. It's not fair to say that individuals with FASD can't be helped. Rather, we need to look at what FASD-informed approaches can do to help us shape and adapt a service. If what we're doing isn't working, it doesn't mean it can't work. It means we have to start asking how it could work. What do we need to change to alter our service delivery or our treatment approach in order to meet the needs of this population? Not a question of can't, it's a question of how, and that comes to us to be creative, adaptive, and responsive. Finally, looking at diagnostic support plans that contain clear information about individuals' areas of need as well as their strengths, because strengths are a critical component of any plan. Those are the things that we leverage and build on to create an alternative pathway for a person forward. So balancing that clear, comprehensive package, strength and difficulty, allows us to do something that's meaningful in our treatment plan. See the pretty picture? I really love what they did. So they take you through the pathways to care for individuals with FASD. It's a lovely little roadmap. It's a nice thing to remind yourself of. It is available online. Like I said, I'll give you the website at the end. It's at the end of my presentation. And you can go in and download it for yourself and use it anytime you want. Looks at FASD diagnosis being critical, what it means to have an invested advocate, primary health care, intake, prevention and wellness maintenance, and then specific mental health and addiction services. It's a nice one to have on your radar. It's a nice opportunity to use pathways like this so that we can be proactive and thoughtful in addressing all of the needs of the individual, as opposed to just responding to that kind of critical incidents after things have already happened. Similarly, we also have an intervention model that we provide that identifies a number of different components important to functioning and healthy mental wellness. There we go, mental wellness for individuals. This looks at different pieces, including things like employment and housing and stability that are going to come later in life if you're working with transitional adults, older teens around mental health. Meaning, if we're not addressing some of these basic needs, do they have housing? Do they have some kind of stability in their life? Do they have financial security? It's going to be really hard for us to address the mental health needs that accompany those stresses. Really hard to help somebody work through anxiety issues when they're living on the street. You need to house them first. So these kinds of models help us to identify some of the surrounding features that encompass mental health specifically. In short, mental health issues are disproportionately represented in individuals with FASD. They're complex, reflecting many complex contributing factors that make them hard to unpack at times, but mean that they're particularly important for us to have informed treatment teams thinking about how we can move forward. Identification is important. It allows for proactive service delivery so that we can get ahead of it and plan for success and not just be reactive. Intervention can have a positive impact. We can see change, and we can integrate these services in ways that are quite meaningful for individuals, particularly when we take a strengths-based approach that acknowledges where they can have success. Support the supports. Advocacy is important and can be nurtured. Finally, FASD-informed systems and clinicians are critical to healthy outcomes, and the training that they receive is essential. So communicating this, becoming advocates, all of you in the room who start to say, hey, have you heard about FASD? Sharing it with your colleagues, sharing it with the people around you, passing it along, sharing some of the resources that allow us to plan ahead, starts to create that window for training. And if we can train all of our colleagues, all of our people, everyone around us, then it's not just the caregivers who have to do the advocacy. A big thank you to a lot of the people who helped make some of this work possible. Couldn't do it without the students in my lab. I can never say any of this without thanking them. There's a website right there, the CanadaFASD.ca. That's where you're going to find those mental health graphics and others. If you go onto that website, you'll find a tremendous number of resources. In fact, there's a whole drop-down menu of topics. You could go through those topics and you'll find lots of articles, short briefs, any kind of information that you might be interested in, all of which is really well founded in research. Boom.
Thank you so much, Dr. Pei. You know, there's so many aspects to this subject, and it's so complex. And, you know, we're just barely going to get a chance to touch on things. So I'm hoping that you'll be having lots of questions afterwards. Dr. Pei, would you like to take a seat? So this evening is also about valuing the voices of those with lived experiences. And so we're very pleased to have a panel that brings some very different perspectives to the topic. I'm going to ask Meg Smale to join us. Meg is a mother of 6 children. 4 of them are her adult children by birth. Actually, you can come sit right here. Come sit with me, Meg. 2 of her 6 children are teenagers by adoption, and both teenagers have significant challenges. The older one is 15 years old, and he was suspected to have FASD. He also has several mental health challenges and is currently living in a group home. Her youngest son is 13 years old, and he has a diagnosis of FASD and Down syndrome plus. So, you know, Meg, when we talk about, I know it's a big room, when we talk about that introduction, that barely even begins to cover your story. I mean, you've been fostering children for a long time.
Currently not fostering, but
Yeah.
we fostered for about 6 years. And I always say my last 2 bonus babies came to stay. And the pictures were up earlier. I don't know where they are now.
They'll come up.
They'll come up. My older son, Jaden, he came to me just before his 3rd birthday. There they are. We were told that he had reactive attachment disorder, and that was about it. He came to me at not quite 3, no language, which was really hard.
Wow.
Little comprehension, less ability to talk to us, so we've worked very hard with us, delayed everything. Little Drew I met him when he was 13 months old, and he came to us as a respite child from another foster home. And when he was released for adoption, I said, that's my baby. I want to adopt him. I had fallen madly in love with him and still love both boys with all my heart. It's hard to have Jaden in a group home, but it's easier on our whole family and him, because his behaviors became so that they were dangerous for his younger brother in particular.
So tell us a bit about what that experience was that led to you making that decision.
Part of it comes to 2 months ago when Jaden disclosed to us that when he was living at home with us, he was regularly punching his little brother. And as a lot of our children with FASD, they both were sort of I wasn't getting the whole story. There was a lot of confabulation going on, making up of stories. They're not really lying, but they weren't able to tell me exactly what was happening. Drew, with his combined diagnosis, has very severe language delays. He tries so hard to tell us what he wants, but most of the time, it's really hard to understand him. Mm-hmm. So we have worked very hard with speech therapy for a very long time. And we've now come to the point where, for clarification, we use an app called a Touch Chat, and we're working on getting funding for a system called a Nova Chat that he can take with him to clarify. For one really good example for him is he says "diot," and I told his staff, "Do you know what diot means?" And they shook their heads and they looked at me. I said, "It means McDonald's." When he wants McDonald's, he says "diot." The first time he told us he wanted to go to a restaurant and he knew he wanted to go to a restaurant, we could not for the life of us figure out what he was trying to tell us. He got very frustrated, and I don't blame him. I'd be frustrated too. And so we have the touch chat app on my phone. We locked it because he's really good at electronics. That's his superpower. And sure enough, out came restaurant, and we're going, okay, we can do that today, or no, we can't. Now we know what restaurant sounds like. But there's a lot of examples like that. He's still, I don't know if she'll like me telling this story, but I have a daughter who's 27 who still lives at home. She has some health challenges, and she's going to university, so I'm being a good mom. And when they first came to us, neither boy could say Helen. Helen is a tough name. H is a tough sound for any child with some delays in language. So my older son started to call her Honey, which everybody thought was very sweet. It was just he couldn't say the L sound. But Drew couldn't even say that, so Honey became Nunny. And she is still Nunny to this day. He still calls her Nunny. And she says, it's probably going to be forever, Mom, and that's just fine. So we deal with a lot of interesting challenges. Jaden's is more behavioral. Drew has a lot of physical challenges in addition because of the Down syndrome. It means he's got a heart condition. He's had eye surgery. He's had at least 2 dental surgeries. One was just last month. So we've gone through lots. He may need another open heart surgery, which I found out as I'm doing my research quite recently that could be related to his FASD as well. And he has a confirmed diagnosis, which was a little tricky because of the Down syndrome. But if you look really closely, you can see the markers for his upper lip and, what's that word?
Vermilion.
Vermilion, thank you. And so they show that, and his eye placement, Dr. Andrews at the Glenrose gave him his diagnosis.
Wow. You have spent a lot of time learning as much as you can about FASD. Tell us about what difference that's made and what you've learned.
It's made a huge difference so I can advocate for my boys to get the services they need. Sometimes I've needed a little extra help, and I've been very fortunate to have really amazing mentors from coaching families to help me. My new mentor is out in the audience somewhere. My current one is moving on to a new job. My first mentor was instrumental in helping us find group care for Jaden. Without her, it's a really hard process. It's not just emotionally hard, because it was the last thing I thought in this world that I would have to say to my 14-year-old son, no, you can't live at home anymore. It's just not safe for all of us. And finding a placement for us. So because they're adopted, we also have support through Support for Permanency, which is an amazing organization that gives us a little bit of funding to help raise these boys. And it also means we don't have a lot of money to spend, but it means also I don't have to work full time, which is really, really good, because I don't know how I'd fit in all their appointments.
Well, I don't know how you fit it in being a single mom.
Yeah, I'm a single mom as well. So having my 27-year-old daughter at home is a tremendous help. She only goes to university part-time. Tonight she is home with Drew. I got an emergency text from Jaden's lead at his group home that he'd had a rough bus ride home from school today, and I'm going like, oh, please get through it. Don't be triggered. Please get through it tonight. Because I never know what's going to happen. Because of his challenges, we often, on weekends anyway, have at least one incident report per day on weekends, and often at least 1 or 2 through the week. So I never know what my inbox is going to bring me when it comes to Jaden. The biggest one was about 2 months ago when he had his big disclosure, and he doesn't like feeling this way, and part of him understands why he can't live at home, and part of him misses us so desperately. So, and we miss him too. We don't miss the rages and the broken furniture and the traumatized little brother, but I do miss the sweet Jaden, who can be a real love. So I get to see him as often as I can. I got to see him yesterday, which was awesome, at an appointment with his psychiatrist at CASA, because we've gone through programming at CASA with him that's been enormously helpful. And I get to see him tomorrow when he has a pediatrician appointment and an appointment with his therapist. And on Monday when he gets his braces off. Yay! That's been a challenge, let me tell you.
As a parent, I have incredible respect for what you go through and how you deal with it. For you and for our next panelist, she is also a parent. Robbie Seal is a super mom, or so she's often called. She calls herself a mom. She's an advocate, and she's a champion for those who are like her. Robbie is a proud mother of 1 biological and 4 adopted children, 3 of whom have been diagnosed with FASD. Robbie is also a former child and youth care worker with experience in children's treatment homes as well as in a secure youth facility. Robbie offers workshops and group presentations for community groups, churches, schools, parents, grandparents, caregivers of children and youth with FASD. And she combines knowledge, compassion, and humor. I love that, Robbie. From her personal experience with expert research to bring a message of hope to parents that hashtag the struggle is real, but so is success. Thanks so much for being a part of this panel. You know, it's interesting, when you and I spoke, you said you were an educator, but there was no education about FASD in the 1990s.
No, when I went to, can you hear me?
Oh, press the button. Top side.
Top side.
Yeah, and this is for you too, Lisa. Yeah, there's a button you just push, and it'll turn there. Yeah, got it? It's off.
Okay, there we go.
Yay.
Yay. So in 1990, when I graduated from Grant MacEwan, a child youth care worker, ready to go out and change the world, working with, at that time, called Emotionally and Behaviorally Disturbed Youth. Isn't that a terrible title? Would you like that label? Emotionally and Behaviorally Disturbed. Not fair. I had no training on FASD at that time, other than to say that children with FASD have spotty memories. They might know math today, might not know math tomorrow. What we do know now is from Jackie's stats is that, you know, many of the children with fetal alcohol land in someone else's care. 86% of them end up in Drew care or foster care or adoption. So it was tragic at the time to be a child youth care worker and have no information whatsoever. Move on ahead another, 10 years or so, and go and adopt my first child, who was also 3 years old and placed with us. So she'd been prenatally exposed to alcohol, trauma, violence, poverty, prenatally, that went on postnatally, in and out of care for the first 3 years of her life. And then with us, that girl was really set up for a lot of heartache, and that path has turned out been difficult. She's now 23 years old. But there we were, adoptive parents, ready to take our big love eraser and erase all the hurts and make it all go away. Meg, what do you say to that?
Doesn't work.
Doesn't work. So we learned a lot. Yeah.
You were nodding and that kind of thing when
I could have given an amen. I mean, my gosh.
So what was Jacquie's talk bringing up for both of you?
Confirmation, affirmation of what I do know. I so appreciate the research because the research informs me and informs my practice, and it completely changed my parenting. So I no longer use traditional parenting models because they don't work with our children. Positive and negative reinforcement, it doesn't work with our children. A lot of love, a lot of repetition, a lot of support, and meeting that brain right where it's at. And in the moment, it might be a 14-year-old chronological brain, but emotionally, socially, developmentally, it's maybe an 8-year-old brain. If she's stressed out or they're stressed out, it might be a 2-year-old brain in terms of how we can problem solve. So my parenting floats and adapts, constantly adapts to where my kids are. And I've got 5 kids, so I'm constantly moving and adapting.
And we have pictures of those 5 kids.
You gotta see the Fab Five.
You gotta see the Fab Five. And it kind of brings up an interesting thing because you have children who don't look like they have FASD.
That's right. Yeah, that's right. I forget what grade it was. I'm gonna pretend my twins there, you can see the twins.
Yeah.
They are now in grade 8. I think it was grade 6, about second day of school. They were just ready to get kicked off the school bus. Maybe that was grade 5. I don't know. My dad's here. He'll correct me. But anyway, they had already hit, punched, and hurt some other kid on the school bus. And so I got a call from the principal's office, and as Meg will attest, when the school phones, your heart stops.
Oh, for sure.
Yeah. So the principal calls, and his first word is, "It's okay, they're all right." So, okay, good. But anyway, first or second day of school, they're ready to be kicked off the school bus. and because of behavior. And I said to the principal, you know this is fetal alcohol, right? You know that they need supervision. You know well, let me rephrase. They're excited. It's the beginning of school. It's a new routine. There's no supervision for them. Of course, there's no impulse control. And he very kindly said to me, but they don't look like they have FASD. At which point my head was off. And he just told me how polite they are. And they are very polite. And when they're polite, not to me, mind you, but not polite to me, but they are very polite to their Sunday school teachers, to their school teachers, all that sort of thing, which is a good protective factor, honestly. Maybe escape by get away with a lot that way. But I had to remind him, they have fetal alcohol spectrum disorder. They have a brain injury, an invisible physical disability, so they need support. So thankfully, they were able to continue being on the bus and perhaps maybe sit nearer to the front, but they can't get away with so much.
Wow. I mentioned those three things. One, humor. You have to, there's so much stress that you have to deal with. You talked about children with the condition and youth with the condition, but what about the caregivers?
What about the caregivers? Yeah. First of all, I have to say caregivers are the #1 protective factor for children with fetal alcohol spectrum disorder. We are there 24/7. We're there when the blank gets real, and we have to carry on, and we have to love. And I edited. Yay! I edited.
Inside joke, everyone.
Last time I did training, I thought I needed a spare jar so I could just go. My husband was there. He told me I needed a spare jar. But no, we need humor because it is so very stressful. But also we see the good and the strength and the positives in our children too. Like I hope as you look at those children, you see those darling faces as well, full of life and love and humor. I love those guys. I wouldn't have a day. Well, I would have a day without them, but I wouldn't change my life for anything. They're fabulous.
Do you know what's interesting, Rob? Because it was caregivers who actually really catalyzed a lot of the work into the strengths of individuals with FASD. We spent a lot of time saying, ooh, let's look how the brain is injured or damaged, what's wrong. And caregivers said to us, you know what, we want to know a little bit more about what's right because we love these kids and they have incredible skills and strengths and abilities. And you guys need to balance your research a little bit. So it's you guys that told us to get on that. Yeah.
Exactly. So back to caregivers, what we do know about, first of all, children with fetal alcohol is the #1 protective factor is to have a family, a stable placement, whatever format that is, but a stable placement. And there's several factors that makes a stable placement, and love isn't enough. We will burn out very, very quickly if all we've got is love. We need training, training, training. Then we need coaching. Yay, coaching families. They've held my hand too. Then we need coaching because we need the ongoing training and training in the moment and holding our hand in the moment because like you said, it's not that things don't work. Well, things don't work, so we have to go, how can we make it work? How can we change family life? My gosh, family life has to change. The drive to and from Grandma's house has to change. There are, one thing we do at family dinners, my dad jumped on this a number of years ago now, and when he sets the table for, let's say, Thanksgiving dinner, adult child, adult child, adult child, all the way around. We call that prevention. Everything we do is modification, and everything we do is caregiver support. So that means a trip to Mexico a couple years ago for Mama Bear because I needed to recharge. That's one thing. Respite. We need respite. We need our families, like my parents who are here tonight, we need our families to join in and really understand what fetal alcohol is because we need support, but also we need our little loved ones to be loved and supported. And do you see those crazy behaviors at the dinner table? The little guy who every time you put down something hot in front of him, he has to touch it. And it doesn't matter if you say, hey, that's hot, don't touch it. Well, he has to touch it 3 times if you said it's hot. So, just to know, what, that's a disability, we'll roll with it. And we need Grandma and Grandpa to understand that. Otherwise, Grandma and Grandpa are going to get really frustrated, and then those family dinners aren't going to be so fun anymore.
I want to come back to the whole concept with family and family involvement as well, but we have one more panelist. I want to get up here first. Lisa Rogozinski is the coordinator of the Edmonton Fetal Alcohol Network and FASD community educator with the Bissell Center. She's been doing this for over a decade. She is also, she works alongside individuals with FASD, their families and communities in assessment, prevention, and intervention. These experiences have given Lisa the insight and experience to develop policy, to build public awareness, to provide foundational knowledge about FASD in Edmonton and surrounding areas. And Lisa believes in a strength-based approach, which I love, of collaboration, compassion, and creativity, where everyone has a voice and everyone has a responsibility to be involved. So thank you so much for joining us, Lisa. First of all, I'd like to get an idea if you can explain what the Fetal Alcohol Network does and what makes Alberta so different with this from the rest of Canada.
Okay, so since 2007 in the province of Alberta, we've had the FASD Service Network program. So the Edmonton Fetal Alcohol Network, we are one of 12 FASD networks in this province, so geographically, every community is covered. And this is a collaboration between our networks and the government of Alberta. So we receive funding. In Edmonton, we receive approximately $3.2 million annually to distribute to FASD-specific supports in the areas of assessment and diagnosis for children, youth, and adults, also for interventions, and all of our interventions are informed by the assessment and diagnostic process, and then prevention. And prevention involves two things: general awareness to FASD, as well as having those critical conversations with women, partners, communities about alcohol, pregnancy, and reproductive health, but also those intensive supports that we provide to women who are pregnant or up to 6 months postpartum who are substance using. And I think what makes this unique in Alberta is that it's the only place that has a model of how we are going to approach FASD as an entire population, as an entire province.
Wow. One of the things that we talked about as a group is how there still is so little awareness about FASD, and that it's the research around it is also quite new.
You know, we really luck out in especially Edmonton because we have Dr. Jacqueline Pei, Dr. Gail Andrew, Dr. Carmen Rasmussen, all the big researchers in this field are in Edmonton.
Wow.
And all of the work that they do, which usually is also a part of CanFASD, the Canada FASD Research Network, informs our practice at the grassroots level.
Mm-hmm. And you have very active parents. And that's why we're so pleased now that both of you are on the panel, because you are also hugely active in helping other parents, in raising awareness. I think, Robbie, it was you who said educate, 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 or advocate, advocate, advocate.
Both, perhaps. Yes, training, 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 and then advocate. Absolutely. And I probably that social misfit, well, no, I am, that social misfit that will be at the party and who will not be having alcohol, and then we'll be having conversations about, they'll ask me about my children. I'll keep it light and glib, but if they probe a little bit, I'll let them know about fetal alcohol spectrum disorder, and I will certainly encourage young women to be very mindful that if they're planning to be pregnant, please don't drink. If you're drinking, please be planning not to be pregnant.
I think that's one of the biggest areas that we have evolved. So I've worked directly in this field since 2005. And when I started, we told women, don't drink when you're pregnant. Now, those of you who have kids know how successful it goes when you tell your child not to do something. It's not successful. And so we've come a long way in our understanding. We cannot look at FASD as simply being woman consumes alcohol, causes FASD. But in actuality, it is this complex web of risk factors and causal links. So our prevention never relies on taglines like FASD is 100% preventable, because it is not. When we look at the lives of women who have given birth to children with FASD, there are lives that are often filled with trauma, domestic violence, poverty, isolation, lack of access to pre- and postnatal care. So our prevention efforts, and Jackie mentioned this, it has to take the social determinants of health perspective. We need to address the reasons behind why a woman is consuming alcohol.
You know, and I'd add to that too, that, and one of the reasons, and some of the extension of this is to add in not just when you're pregnant, but if you're planning to become pregnant. Because a lot of times women consume alcohol not knowing they're pregnant. And that's a group that we're just kind of beginning to understand. And we're saying, well, what does it mean to say, well, I want to have a healthy pregnancy, so what are the things I do to even think about having a healthy pregnancy? And changing that conversation even before that. Yeah.
One of the things that we also talked about too, and I'm going to bring it up, is the stereotypes around this, and that sometimes that affects people's perception of what's okay. And it is an educated audience, because when you talked about how, what's an acceptable level of alcohol, and the reaction or the response to people in the audience, that's not the response that you generally get in the general population.
I agree. I was really surprised, and I think sometimes, and I should ask you guys, but when we come to events like this, you do encounter a lot of folks who have some knowledge, and they're coming because they already recognize that it's important. And then there's those folks that's not even on the radar, and there seems to be a gap. I don't know if you experienced that too.
Yeah, there's a tremendous gap. When I am out in the community, or perhaps I'm at work, and somebody asks about the kids, and I might say that, well, they have a brain injury. I'll start there, because FASD, gosh, what does that mean?
Yeah.
So I'll start with, they have a brain injury. Oh my gosh. See, then I get mercy and kindness, right? See, I'm smart. Brain injury. And well, how did that happen? And I'll say, well, their birth mother drank alcohol when she was pregnant. My God, why would anybody do that? Is the judgment. Well, first of all, let's just back it up again. There's reasons why women drink alcohol. Also, can we concede that some of us have had pregnancies unplanned? Mm-hmm. I had one pregnancy, not planned. I mean, it happens, right? So
50% of the time.
50. I had mine was 50%. Mine was 100% of the time. Yeah. Well done. But I mean, so let's just back it off a little bit and from judgment. But then the next question is, are they native? Which I heard them. I heard them preach it over there. Yeah, and I got to say, no, they're not. And that's that's a very offensive question. No, they're not. And then I go into the stats about Russia has FASD and Australia has FASD. This is not a Canadian Indigenous population problem alone.
Did you want to add to that?
My kids are Indigenous. But I mean, that doesn't mean that there's also a high Indigenous population within the foster care system, which is where they came from.
That's right.
So it's not just that. And I do know that both their mothers, their birth mothers, 2 different birth mothers, were both living on the streets during their pregnancies, and who knows what they were having to deal with. I know my younger son's birth mom was dealing with a lot of violence on the street. And so the fact that he came out as intact as he did, and he's a delightful little boy who will always be young at heart, is okay. I don't, he's still my son. I still love him with all my heart. He's one of the kids that is not going to go on and live independently with supports. He will always need supports where he lives. And that's okay. In fact, that's both my boys. Because of the trauma that they both experienced, pre and postnatally, they will need lifetime supports. So I've had to go to my adult children, and mostly my daughter who lives at home. And she has said, yes, Mom. When you can no longer be their guardian, I will be their guardian. And that just melts my heart. When I adopted my boys, I was not 30 or 35 years old anymore. And Children's Services said, look, you need to have someone on your adoption order that if something happens to you, or now my ex-husband, that they would be willing to take the boys in, because Helen was under 18 at the time. My wonderful baby brother and his wife agreed to have their names on their adoption order. So I have support from my family. They don't always totally understand. In our family, my daughter Helen and I are the only ones that really get the boys, but I've been blessed with a good circle, coaching families, the CASA Family Advisory Council, which I always also sit on, plug for CASA. And
It's an amazing group.
And the group home that my 15-year-old lives in, his lead staff in the house is absolutely phenomenal. She tried to call me. She knows I'm busy tonight. I'll call her back later, but I don't know what my son would do without her giving that extra piece of advocacy when I can't be there. She's the one that says, no, he needs consistent staff. No, he does need the alarm on his door at night when you put him to bed. And make sure the supports he needs for him to be safe and for his housemates to be safe are in place, and for him to have a healthy life in the community where he's living and going to school. So you build that community if you don't have it with your family. I must admit my 3 older adult children don't always understand what I've done. Mom's a little crazy to do this. Shouldn't you be retired and enjoying your life now? That's what I got from my oldest son, who's almost 40. So I said, no, you need 2 more brothers. And I adopted them. And they've accepted them, but they still don't always understand, because I also have 5 grandchildren and 3 step-grandchildren, so it sort of makes my life a little bit more interesting.
You keep saying that. But it really does bring up a point about support and how important support is. You've each got daughters who are at home, who are helping. You've got none? Okay.
But they hit the bricks. Yeah. And no, actually they they love the kids, the 2 big ones love the kids, but they find it a lot. So my oldest is 27, and she'll text me or call me, hey Mom, I miss you guys, can I come over? Definitely, come on over, come and have supper. I mean, supper is a stressful time in our house. Sure, come on over, have supper. And she'll be there for a couple hours, and then she bounces. Because it's a lot of stress. Because like I said, we're always managing, we're always accommodating. To come here this afternoon, I was here early, but to come here this afternoon early meant that I disrupted routine to be here. That caused 3 meltdowns in 3 separate children that had to be intervened within moments, and I was the only one home. My husband's working evening shift, and my respite worker was running late, so I had to support 3 very dynamic, highly stressed kids ready to melt down, and knowing I would be walking out the door in 5 minutes. So yeah, no, I don't have big kids living at home, and they wouldn't want to live at home. I might also say, if you don't mind, is that my second oldest, so as I say, daughter number 2, we just number the kids. It's easy, right? 1, 2, 3, 4, 5. It's just easy. So number two, she's came to us at 3 years old through a foster to adopt program. We adopted her when she was legally available. That was 5 years old. Keeping in mind, this little girl had been in and out of care from just weeks old. Okay, and her brother's also in and out of care since weeks old. Adopted her at 5 years old, thought love would erase everything. Had a difficult marriage that declined over time, so we too had ACEs, adverse childhood experiences. We had a bad marriage, and we had violence in the home, so it was bad too. That dissolved in 2010. By 2011, that daughter, then 14 years old, was addicted to substances and on the streets. I too had the experience of saying, she was on the streets, and I got supports for her and tried to get treatment and addictions. And even in addictions treatment, she still wanted to be living on the streets, and she was struggling in addiction. And when they said, Robbie, we've got to kick her out of the program because she brought substances in, you have to come get her. I was single parenting and had a couple of 6-year-olds and a 3-year-old at home, and I said, my gosh, if you can't keep her safe, how do I keep her safe? If she's not safe, she's using drugs and alcohol, she's self-harming, she's running away, she's running around with men that are 20 years old, and she's 14, how in the world can I keep her safe? And she will be harming to my other little children. And although I say it calmly now, it was the most heart-wrenching decision of my entire life to say, no, she can't come home. Which moved her into supported living, a safe house, where she was safe for the first 3 days because she wasn't allowed to go anywhere. And the day she was allowed to go anywhere, she took transit, ended up partying with who knows who. We had lived in Beaumont. This little girl doesn't know Edmonton. Suddenly she's riding transit. And the police, let's just make a short story, the police brought her home at 1 in the morning, drunk as anything, and said, does this belong to you? That's how some, not all Edmonton Police Services, I have a lot of respect for Edmonton Police Service, but that's how some people deal with our marginalized youth, our troubled youth, our, what do we call them, emotionally, behaviorally disturbed youth. Does this belong to you? You know, no, this is my daughter, but she can't be here right now. Now that daughter went on to be on the streets for about 7 years, in and out, trouble with the law. Did we talk about that? Mental health, addictions, homelessness, all of those stats. Jackie had all those stats. I'm like, oh, that's my family up there. Gosh, you know, I'm a little church girl. How did that happen? You know, but that's our family. That's our reality. But that darling girl did land for a year in jail. And while there, got time to be clean, sober, 3 squares in bed. That helped that little girl a lot. I accepted the invitation to go to treatment and spent a year at, now it fails me, Appleton Teen Challenge, which offers many programs internationally, but a women's program in British Columbia. And she loved it. She took to it. She accepted the treatment. And my daughter graduated from that program more than a year ago. And then she decided to stay on with further support. So that includes housing, right? Housing, training, job security, all those protective factors. She chose to stay on for another 18 months. So my daughter is 23 years old now, clean, healthy. So I'm really thankful for that.
Wow. Pretty tough on marriage when you're going through those things with children.
Incredibly difficult for mom and dad or partners to be on the same page. Because first of all, you have to accept, you have to believe there's such a thing as FASD. Because the wide community around you doesn't believe or know or acknowledge that there's an FASD. And when children look neurotypical, fancy word for they just look normal as my kids do, then this is just really shitty behavior. And if you just disciplined more, if you weren't such a, these are the things we hear, right? You should be more disciplined. You should be more consistent. Oh, you're just so overprotective. Why do you go with him to every birthday party he goes to? You know, either you're overprotective or you're lenient. I got an amen over here too. Mary Ann just gave me an amen. Why can't they take Edmonton Transit to school? You know, like I'm overprotective or whatever. So it's hard for parents to be on the same page because you get all this contradictory information, and certainly how I was raised or a spouse was raised will not be how we have to raise these children. We may have been raised very, very, very well, and we were, but it doesn't apply to these children. The one factor that does apply is the unconditional love and the willingness to learn and do the very best for our kids, and that's what we do. And I was just speaking to one of my mentors earlier, I haven't seen for years and years now, and I said, my husband has drank the Kool-Aid. He believes in FASD, he believes everything I've learned and now teach about FASD, and then he holds my feet to the fire when I forget, because I forget, and I want a discipline, and I want a consequence, and then he reminds me, remember, Robbie, they don't learn from consequences. So how do we need to prevent and protect?
And one of the other things that you told me that made a huge difference is when you finally said, you changed your way of looking at it. You said, this is a brain injury. It's not, and you looked at it from that perspective. If I don't look at them as a 12-year-old, but the fact that they're really half that age and treat them accordingly, that made a huge difference.
Well, I think that comes with being FASD informed. So when we talk about system barriers, and it's not all systems, and it's definitely not all people in these systems, but the lack of being FASD informed. So many systems require that the individual with FASD, in order to fit the eligibility criteria of that system. And what we need, or what we see because of that then, is it's the people with FASD who don't have a physical disability that you can see falling through the cracks of every system. So we need to do a shift, and we need systems to change, to be adaptable, to be flexible in order to meet the needs of the individuals with FASD, their parents, caregivers, and families.
Absolutely.
Yes.
Did you? No, actually.
I'm nodding a lot because I'm agreeing with everything. Lately our biggest challenge has been with my younger son Drew's school. And this has been a really tough grade 7 year for him. He's in a program called Community Learning Skills, which should be a great fit for him. but we've got staff that have been teaching a long time and know everything, and weren't really willing to learn a whole lot. The more I shared, the more difference we got. I've got a 13-year-old sitting at home now that says, I'm not going to school. There's no way I'm going to school. He's just tired. He's done. My daughter and I are trying to figure out how we can make this work for the rest of the school year. And we think we have a plan. With our current Coaching Families mentor, we discussed the plan, and the email that I sent off to say, we got to make this work. And then there's the problem with transportation and boundaries within Edmonton Public Schools. They won't drive kids across boundaries, even if a program is a better fit for them. So I've been having a lot of fun trying to educate, and they're not listening, and I'm getting frustrated. The only one who listens, it's funny because I work for Edmonton Public Schools too. But I work, go figure, right? I work as an administrative assistant, and I work with consultants. I work in a building that has consultants only, and I go and whine at the consultants from time to time, and they agree with me. So it's all good, so I've got my support at work too. But it's been trying to get the word out. All they see, and this has been happening as he's gotten older, is this cute young man who has Down syndrome. Mm-hmm. They don't see the brain disability that complicates that Down syndrome. So when he sits down on the floor of the LRT when they're on a field trip and won't move, we have a problem. He's 4'6", probably won't get a whole lot taller. He just had a growth spurt. And he's almost 100 pounds. I can't move him if he doesn't want to go to school. My daughter can't move him if he doesn't want to go to school. And I don't want staff to get injured moving him because they think he needs to do something. They just don't get that they have to give him time. They need to bring along extra support on field trips, and so that he can have a comfortable life. But he probably won't finish grade 7 there because I don't think I'm going to be able to get him to go to school.
It's complicated. I mean, it's complex. There's so many different sides to this. What are some of the solutions? You having seen things and experienced, big picture, being involved in it, what are some of the solutions sort of going forward? What do you look at and say, boy, if I were in charge?
Gosh. I think training is one of the ones that we come back to. I mean, it's not a full solution, but I do think that all sides, I really appreciate that we say look at all sides, because I think that frustrations with the education system, for example, are really common, and it's one of the biggest challenges, I think, for a lot of families. But I also don't think that a lot of educators and systems are actually aiming to do things wrong or trying to, so they're in this trying to do the very best they can do based on the training they've had and the resources they have available to them. And so there's a real disconnect that's occurring in terms of how we're making sense of understanding and responding. And I don't think when the training means just going in and saying, here's FASD 101, now go do your job different, because I don't think the systems are shifting and allowing them then to actually respond differently. So I think that when we talk about doing training, we're talking about really shifting a little bit into increasing capacity to really work from an FASD-informed approach, so that educators can not only be in a position where they can kind of do the things that Meg and Rob, you're talking about in terms of seeing and understanding behavior differently, being proactive or preventative, knowing how to alternate the adults with the kids at the table. I mean, recognizing and seeing things like that are huge in terms of what they actually mean for whether or not you get through that meal. Yeah. So in a classroom or in a school-based setting, not only creating the kind of knowledge base that educators can be that creative and flexible, but then building that into the system that allows them to do so they don't need to be so pressured to meet curriculum goals and teach to big classrooms all the time, but rather have the versatility to say, you know what, this child's safety and well-being actually has to be more important than whether or not they learn this particular math fact today. and to get the freedom to do that and the room to do that. And I think that there are schools and places and spaces that it's starting to happen. I know we've heard from some educators. One of them is here, and I don't know where she is because it's all dark out there. But it is happening, and it can happen. But I think it's a slow shift, and I think that as education and training initiatives step in, and as we really listen to the caregivers and really partner with the caregivers, I think that will become more of an embedded training model, not just they drop the knowledge down and think that people can suddenly do everything different, because it doesn't work that way.
That's right. And you said earlier in your presentation, Jackie, that relationships are the key. Relationships are the key to success, and that's true at home, it's true as families. As we advocate for the 1, 2, 3, 4, 5 that we have, then that's a ripple effect. And we're then advocating for the next people that individual encounters. But also relationships at school. I'm sure Megan's working very hard to establish relationships at school. I mean, and that's what she's trying to struggle at school. Who would she look at? Because she knows I've had trouble. I mean, if you have a child with a disability, you've had trouble in school. Marianne was here, she's going to give me an amen again. It's tough. It's really tough. But I've worked very hard, as the parents here have, to build very positive relationships with my school. And I consider them part of my team. And I tell them, you're part of my team, and I welcome you on my team. And I when I get across my email information about FASD or this event, I forwarded it to my team, and I blasted every email at school I have, and I collect. I don't delete my email, my addresses, right? So I blasted every event at school. Hope to see you there. So I hope there's some AKE representatives here. But I invite them to training. When Donna DeBolt is a trainer, does a lot of FASD training in Edmonton, and when she has an event, I invite my teachers to come to the event and advocate with my principal to get those teachers funding so they can come. And over the years of being in our school, we had more and more and more teachers take that training. And one thing that May said is a teacher who's had many, many years of experience and not very receptive to understanding FASD. I had one of those teachers for one of my girls and then also my son. Then she took the training, the FASD training. I'm telling you, she was emailing me from training going, oh my gosh, I'm going to change so many things. I get it. So thank God, right? And it made a big difference for my son. Now she's still in training because it takes a lot. And so she superimposed that information over my son, which I'm very helpful for, but I know she had 4 others in that class at FASD, and she didn't quite superimpose it over on them. So we still have a long way to go,
And I think alongside the training too, though, it's not just a one-stop shop training. It's those case consultations that hand over hand, how do we apply what we learned each and every day? And groups need to get together and to share that information with one another and then pass that knowledge on.
Very true. And one of the groups that does that a lot, it's really short, is parents who have, my friends are people like me in terms of they've got these crazy challenging families too. I would say my very dearest friends are people who have foster or adopted children as well with complex diagnosis. Everybody else falls by the wayside because, well, you're not welcome in their home. Because if it ain't broke, it ain't ours. And if your house is going to get broke. So, sorry. But that becomes who our friends are, but then we learn and we share from each other.
One of the things that I read a lot is that there are a number of adoptive parents who don't know when they're adopting that they have a child with FASD. And, you're both very strong and competent and sharp. And not everybody's in a position to be able to advocate, or not everyone has, got the gumption or whatever to be able to go out there and advocate for your child at the risk of other people, being antagonistic or being viewed a certain way. So what kind of support for those people?
Coaching families.
Yeah, coaching families and education. And I'd like to say my younger sons, I've had now almost 40 years of advocacy because my older 3 children all have learning disabilities. So we've done the Academy at King Edward with one of them. And my 27-year-old developed a health issue in grade 8, so then I had to be advocating with the school for her. And it's funny because my boys, when they were in kindergarten and grade 1, had the same principal that gave us challenges when she was in grade 9. And she still gave us challenges, but that's okay. My kids aren't in any of her programs anymore. And I do advocate in a really positive way. I do my best when I share emails. Boy, do I send a lot of emails.
I put pink hearts on mine. What do you do?
I don't know about pink hearts, but I make sure that everybody gets the email. Like today's email, that Drew hasn't been in school because I can't lift him to put him on the bus and he is refusing. It went to the principal. It went to the 2 teachers in the program. It went to inclusive learning programs through Edmonton Public. So the supervisor, the OT, the 2 SLPs, speech and language therapists that he works with at the school, and to my coaching families mentor, and to my adult daughter who helps me. I consider her a second parent in the home because she can take my boys to appointments just as easily as I can, and she knows everything that's going on in our home. But I make sure everybody gets CC'd.
And I hear that as kind of like advocating, everybody please know the situation Drew is in. Also, everybody please help me.
Yeah, exactly. I even
Somebody please stand up and help me.
And Lisa was asking me earlier, did you get many responses? Because I even posted on one of our Facebook groups for families that are raising children with FASD. What are we going to do? Anybody have any ideas? Any resources that I can use with him? I gave a description of my son. And I got a couple of the responses where he's probably just done for the year. And I think he's just done for the year. It puts him at risk for not getting his Nova Chat, but we'll work around that somehow. But he's just done. He's tired of school. He's tired of the noise. He's in a regular junior high with this program. The school thinks it's okay to play really loud music in the hallways all lunch hour.
Has anybody in this room been in a junior high lately?
So,
Like, my gosh.
Yeah.
It is the stinkiest, loudest, most obnoxious place to be. And imagine having a brain injury and not being able to communicate.
and
No
her
wonder
sensory
he's done.
integration disorder as well. He did the Fast Tracks program at CASA, so we got a sensory profile of him. This kid was over the top in every sensory area except one, and he was high on that one. So you put him in an area where one time when I took him back to school after an appointment, they had put the 2 community learning skills programs together in one room. So there was probably 5 or 6 adults and about 20 kids with disabilities, variety of disabilities, all in one room at the same time. I felt overwhelmed and dysregulated just being in there for the 5 minutes to drop him off. I can't imagine how he survives his day. So people need to understand that a lot of our children with FASD have sensory issues as well, and getting them to a good fit for a program that'll suit their needs is really challenging. There's not a lot of programs out there. Academy at King Edward is a pretty good program. My bio son wasn't impacted by prenatal exposure, so he did really, really well and moved into their high school program as well.
I'd say it's a great program. It's not FASD specific.
No, it's not.
So they're striving. It's
Striving.
a great, very supportive program, small classrooms, expert teachers, definitely a lot of accommodations for students, but FASD is a whole other thing.
It is. And when my older son went there as well, Jaden went there as well, and he was going into grade 4. His grade 3 teacher was absolutely phenomenal. We took a look at his test from the Glen Rose for the SNAC program, and they sat me down and said, I don't think this is a great fit. He's emotionally very immature. He's going to go into grade 4 with these kids, for the most part, have learning challenges, but emotionally they're pretty good shape. They're going to eat him alive. And so at that point, they had 2 different programs. One is being stopped. The literacy program is being stopped. And there's an opportunity program. So we chose an opportunity program for him. First 2 years for grade 4 and 5, it was absolutely phenomenal. We always told the staff that we suspect FASD, and this is what it means for him. The school made a mistake and put him in a different class for grade 6 with a teacher who expected homework every night in math. I heard that. Yeah. Yeah, and so I sent her notes regularly, said he is not going to be doing math homework anymore. He's not going to do any homework. At the same time, he was doing the TAG program at CASA, Trauma and Attachment Program, and so we were up to our eyeballs in therapy and treatment and homework, and that was not a good fit. Grade 7 and 8 at LY Cairns was absolutely phenomenal. They get our kids there for the most part.
And that says something, because grade 7 and 8 for any child is the armpit of life.
Oh, it
One
is.
junior high teacher told me. Grade 8 is the armpit of life.
Oh, it's terrible.
Right? And classy, right? But think about that for a child who is, chronologically 13.
Yes.
But let's say developmentally 8 years old or 6 years old. Hormones galore, but developmentally 6 years old. That's going to be a very complex time. And for you to say grade 7 and 8 was great, that's tremendous.
And he's even had a great year in grade 9. He lives in Parkland County right now, and they have an amazing program, and I have to give it a shout out at Broxton Park School out there. If anyone lives out there, they call it the REAL program, and it's been a really good fit for him because his hormones have really surged in grade 9. Wow. And we've been some really awful things that he's done, and almost got kicked off the school bus. I'm not going to go into why, but almost can't go swimming pools anymore.
So I want to reach out to the audience now, because we've been hearing about the experiences here. I am sure with this audience that you're coming at this either as a caregiver or as an educator or as a social worker. I'm sure that there are lots of things going through your mind that maybe you'd like to bring into the discussion as well. We're a little short on microphones, so I'm going to walk around with a microphone. Who wants to ask a question?
I don't have a question, but I just want to commend these two ladies that adopted these children. Yes, because I work. I don't really want anybody to hear me.
We want to hear you.
Yes, we do.
I work with Catholic Social Services. I'm a family enrichment worker. I've been with the agency for 20 years, and I've been in group care for 10 years prior to this. And the kids that are in group care, I mean, it's kind of one of those last steps for them.
Yeah.
But I just want to commend you two ladies for doing what you do for these kids, because a lot of the reason why kids bounce around in care is because when they find out the behaviors, when they find out there's fetal alcohol, when they find out there's different diagnoses, a lot of people are not either willing to take them on or are not trained properly, and therefore things fall so quickly.
Yeah.
That they just can't handle these children.
Yep.
So for you ladies to do what you've done for your 5 and your 2 boys, I mean, I applaud you. Just listening to what you guys have done is just tremendous. So thank you.
And actually, that kind of brings up one thing. One of you told me that fairly early in the game, somebody said, well, why don't you just give them back?
Is that you or me?
I don't know, but I do know that my biggest fear at one point is that, I'll share, my ex-husband had a massive stroke about 10 years ago, and my biggest fear was that I was going to lose my boys. I couldn't lose something else. I'd lost my husband because he never came back the same way, but I couldn't lose my boys. And my second greatest fear is when I had to put Jaden in group care, I didn't want to give him back up to the system because I've worked as an educational assistant in a junior high behavior class with kids, a young man in particular, that had had 2 failed adoptions. And I know what it did to him, and it broke my heart. And so I knew I couldn't do that to Jaden. Deep down, he's got an amazingly sweet heart. When he sees me at appointments, he is not afraid to cuddle up to his mom in public, even though he's now taller than me, which I hate to admit to him. I told him he was never going to be allowed to be taller than me. I'm feeling shorter all the time. One of the shortest people in my family. So Drew will never be taller than me, so I've got it made, right? But I didn't want to have him go through a failed adoption because we couldn't manage his behaviors and be safe at home. And for me, number 1 is safety. Drew wears a GPS monitor when he goes to school because he bowls. So I know every minute of the school day where he is. And he now uses it as almost like a security blanket. On the days he's willing to go to school, if I forget to put it in his pocket, He reminds me.
There's a question over here.
Hi, I'm an educator and I'm also a parent of 2 children with FASD, and I'm wondering if anyone can address the new research that's out there that is saying alcoholism within the fathers is also now being seen as contributing to fetal alcohol disorder.
Yeah, for sure. There is new research now where we're looking at contributions of the father to fetal alcohol spectrum disorder. The contributions that we're looking at are genetic. So what it means is that dads that consume alcohol, it affects the genetic material in the sperm. That genetic material is then passed on, and if mom consumes alcohol during pregnancy, the vulnerability to the effects of that alcohol, that teratogenic effect, is increased. So the genetic exposure that the sperm gets doesn't create FASD. What it does is elevate the vulnerability to the prenatal alcohol exposure. So it increases the likelihood that we'll see there. So it's just one more vulnerability factor, and it means that alcohol is going to have an impact. Now, additionally, we also know that outside of FASD, the genetic impact to the sperm can still affect the development of that child. That's not FASD if mom didn't consume alcohol, but it does mean that the genetic material has been affected, and that can affect the development of that child and can have mental health and cognitive implications. So the story as it continues to unfold and evolve is that both mom and dad matter, both mom and dad are important, and alcohol consumption has impacts on a child that are contributed to by both mom and dad. So when we're supporting healthy babies and we're supporting healthy pregnancies, we need to be supporting healthy communities and healthy couples. And that applies to both men and women equally now.
And Lisa, that's where I guess when we talk about this, things have really changed. It used to be about gloom and doom, and now it's about healthy families, healthy babies. Not that this is preventable, but we can, that this is one simple thing that we can do that can really change the outcomes and what that means for society all the way around.
Absolutely, and I think the shift we've seen is we now recognize that FASD is not solely a woman's issue, and it's not just a man's issue, it really is a community issue. Just as the parents need to increase their social support networks outside of family members often, we need this issue to go far and wide, that everyone decides to become involved and to have conversations about mood, sex, and babies.
Okay, questions? Yeah.
Hi, thank you so much for your stories. I'm a foster dog mom to 2 children, and our little girl is 6, and she was prenatally exposed in a very complex way, so it all makes sense to me. But I guess I'm sad because that's 9 out of 10 statistic. So I guess one of the questions I have is how preventable is that 9 out of 10 statistic with good accommodation, which we're really advocating for now, because she's incredibly beautiful, smart, and creative. So I want to keep her healthy, of course. And then also, I think there's a lot of hope. I don't know if you've heard the change makers who have become quite a force at the International Conference on FASD for adults living with FASD successfully and parenting. And also the challenge we've had too is that you can't get a diagnosis till a child is 8. So we've had an ASD diagnosis, which doesn't make sense anymore, because while she started at 3, really quite nonverbal, now she's almost completely achieved language and communication and is incredibly engaged. So it doesn't even make sense anymore to talk about ASD, although some of her behaviors overlap with that. So I guess I would like to be a voice of hope, and also to just honor people living with FAS who are successfully living with that. Thanks.
when that stat was on, when Jackie's stat was on that said, what was it, 9 out of 10 people with fetal alcohol spectrum disorder also have mental health challenges, I leaned over to Leslie and said, my heart is ripped right open, right? And as is yours, Mama Bear, you know, because what is the perspective? What is the, but I too have hope. You know, I had one daughter who was affected by trauma, prenatally, alcohol, polydrug user, poor nutrition. Yes, she did slip into addictions. Yes, she did slip into homelessness and trouble with the law. But you know what? Now she's 23 and she's doing really well. And if I might say too, for my next 3 children, very different different biological mother, but very similar story in terms of prenatal environment. You know, we've done a lot of work with these kids, and we have a very safe, protective home now with a very good fit, and my children are doing very well. You know, and so we will say we are successful, and then we're going to frame what does success mean. Right? So, you know, we've got all kinds of crazy behaviors. We have strange interactions at times, but you know what? We don't have homelessness, we don't have addiction, we don't have promiscuity, we don't have trouble with the law, and we're 14 years old, so yay! You know what? And they're on a good path. And we do know, too, from trauma-informed care that, there's adverse childhood effects, but you know what? A love, safe, nurturing home, and many adults that love that child and speak hope into that child and get that child, does a lot of healing for that child, heals that trauma.
Yeah, and it really does. Therapy and intervention matters. Stable caregiving environments matter. It's one of the best outcome indicators we have, these kinds of environments. What you can provide really matters. That statistic describes populations right now, but it's not a predictive number. It's not a predetermined number. So what that number is going to look like in 10, 15, and 20 years as we get better at responding to the population, doing preventative work, I think it's going to change. You're absolutely right. There's some tremendous success stories out there. Success looks like a lot of different things for a lot of different folks, but it's there and it's real. We recently did some work with adults affected with FASD, capturing their successful experiences of obtaining and maintaining employment. And so not only is it a matter of what they're not doing, which are important things to note, but actually a large number of individuals are, just as the crew you're talking about described, they are change makers. They are out there advocating for themselves. They're employed, they're working, they're contributing to communities. We talk a lot now about the physical issues associated with FASD, chronic pain, diabetes, arthritis, all of these premature medical conditions that emerge in the population. The reason that we're starting to talk about it and we're doing research on it is because those change makers spoke up and said, we want you guys to start studying and researching this because you're not talking enough about what's going on in our bodies. So not only have they got successful lives and are they creating meaningful futures, they are now contributing to the research being conducted to improve outcomes for those kids coming behind them. So I think there's tremendous hope and tremendous potential. I think the kinds of conversations that we're having today and the kinds of caregivers that are kind of leading the way and that you can connect with and continue to connect with are going to create lots of stories. That said, I do think that we still know that those vulnerabilities exist and that mental health diagnoses are also not the end of the road. And that even when somebody does present with a mental health difficulty, when they're struggling with anxiety or depressive disorder, for example, when we anticipate it, when we're prepared for it, we can respond to it, it can be treated, things can be resolved, and you can see difficulties resolve and turn into success. So knowing those numbers isn't about predicting failure or predicting difficulty. It's about creating some anticipation that allows us to be proactive, be preventative where we can be preventative, and then get that treatment on board quickly, responsibly, and reduce some of the secondary complications that arise when we don't.
Beautiful.
Hi, Sorry, I just wanted to provide a slightly different perspective that I see my role here today as a mental health therapist from a preventative perspective because I work with young parents. So the clients that I work directly with are all biological parents of their children. The children are in the 0 to 6 age range, and so from my perspective, I'm working to help reduce stigma for those who did consume during pregnancy, and for the many reasons that you've all listed today, but in the recognition that the stigma that they're going to receive as they go out into the community, because they can't be applauded as foster-adopt parents who have taken on these challenges, and instead they can face the stigma of what happens when you consume during pregnancy. Some of those reasons may be due to not knowing you're pregnant until you're 26 weeks along, for lots of different reasons, as well as the ones you've mentioned around environmental and kind of socio-economic and other issues. So I just wanted to kind of plant that as a perspective in terms of prevention and awareness that my youth are going to continue to face as they go out, not just to help recognize that among their own children and in their own situations, but because we know diagnosis is difficult, particularly because sometimes we don't have disclosure that there's been exposure for obvious stigmatizing reasons, but that's a challenge that I face every day with the clients that I serve and work with. So that's just kind of one part of that. And I know, Lisa, that the work that you do really impacts that population as well, so I appreciate that. But then also I have questions around in adulthood. So most of the work that, even the challenging work that you do as parents to advocate for your children in a school setting, which is fantastic, and if you can get an entire school and even just a teacher, even just an aide wrapped around the need for that, that's excellent. And then when the children grow up and move out into the community, I mean, and we see that we have functioning people all around us who live. I know I used to work with a colleague who had the worst memory I have ever encountered, and she blamed that regularly on her mom's cocktail drinking in pregnancy, because in the 60s that was the thing.
Yeah.
So I think there's some people who work in our field who have an awareness around that, but I'm curious what is out there, Jackie, in terms of research and support for adults who live with FASD. So that's my two-part comment. Thank you.
Great. The short answer is there's not enough.
Yeah.
You already knew I was going to say that. But it's coming. We're getting better. We're trying to do a better job of understanding trajectories. FASD affects every brain. Alcohol affects every brain differently. So understanding a trajectory is hard. We have developed some resources. If you go into that website that I showed you guys earlier, that canfast.ca website, where we built things like employment guides and housing resources and things like that for adulthood that are based out of some of the research that we've pulled together to date. And it's work that we're hoping to follow up on to monitor some outcomes. And it's geared towards supporting folks, for example, who are helping out with supportive employment or other employment initiatives, much like you'd help out in the school, but to walk them through the unique needs of the individual with FASD. So it's intended to be a support guide for folks in employment fields, or in housing fields. So there's a couple of materials there that will hopefully help some of our service implementation, and that we're also hoping to study around outcomes. So there's stuff coming. We're learning a little bit as we go, but we're also trying to simultaneously produce some kind of resources so that some of our research can actually happen in real time. Because we can't wait for us. We're really slow. Researchers are slow. So we got to get stuff out there. And then we're really fortunate, too, that we have these kind of community partnerships. Being able to work with these guys changes everything, and all of the community partners and the incredible organizations in Edmonton and area where we can look at studying outcomes and support continuous program improvements.
Yeah, so we do have FASD-specific mentorship programs for adults in Edmonton. McDaniel Youth Program, I see one of the staff here, Brittany. It serves up to the age of 21 at intake, and then we have the one-to-one mentorship the FASS program at Bristol Center. We also have a lifelong program with unlimited potential for adults, and that is the Open Arms program. And these are all programs and agencies that are involved with the network that have to stay, they have to collaborate and partner, that's part of the agreement to get funding. But they are FASD informed and take the knowledge of all of our researchers at CAN-FASD and apply it to the work that they do at ground level.
And they collect stuff, and we keep working with them. McDaniel being a great example, we keep flogging McDaniel, but it's a nice example. But yeah, I mean, thanks to these programs, because the staff are, it's really, those of you who work in business, it's tough to invite researchers in and say, how do we do business better? Because then you kind of expose yourself to hearing that maybe you're not doing it great. Like, it's a vulnerable place to be in. And yet all of these staff open their doors all the time and say, help us learn, help us get to better outcomes, help us figure this out. So we do have some really incredibly motivated program folks out there and organizations that, gosh, we're lucky. This is a really fortunate community.
Wow. I want, it's now getting close to 8 o'clock. We promised that we would finish on time. So I want to finish off with sort of last words. We have barely scratched the surface with the conversation tonight, but hopefully we've begun something where the dialogue either begins or continues and it grows. So, Meg, what does that look like for you?
To never give up hope. My boys will have a productive life, whatever that looks like. It may not be someone who goes to university, and that's fine. It may be someone who, I always swear that Drew's going to be the Walmart greeter, so watch out if he's in your local Walmart, because you will get the biggest hug. And that's okay. As long as they have a productive, happy, safe life. Safety to me is critical. Drew just suddenly started to figure out how to open cupboards, IKEA locks, so we've had to change all our locks in our house. He finally figured out how to turn on the stove at 13. We had to hide the knobs for the stove. So I never give up hope that he's going to learn something new. It may not, like I say, he's not going to ever go to university. Jaden probably won't, but it's possible that Jaden may be good in a trade at some level as an assistant. I don't know for sure that he won't with the right supports in place. And like I say, Drew will probably be a Walmart greeter, so watch out.
Robbie.
Yeah, I know.
The hashtag is, the struggle is real. Have you heard that today? Can you imagine this in your family? Debbie, AKA, can you imagine this in your classroom? My gosh. The struggle is real, but so is success. Meg, look at what she's championing, and she keeps saying their success. Me too in my family. There's success. My kids are loving, they're attached. They're striving. Elizabeth, one of the twins, came home yesterday and was telling me she was learning about budgeting at school, and the example she was giving presented to her, and she was telling me what a terrible person, not terrible person, but what a crazy spender that person was. And she was giving me information about what budget should look like. And I thought, oh, can I tape record this for later? But she's learning. She loves you. When she loves, she makes you a gift. It's wonderful. I too speak hope. Yes, there's hard days. There's hard days, as I said to my mom. This day was as 1,000 days. If you know scripture, you know that scripture. That days are as 1,000 days sometimes, and that's how my days sometimes are. They are as 1,000 days. The amount of trauma and struggle and pain we've had in the month of April alone would curl your hair. It's been crazy. But still, hope prevails. The struggle is real. So is success. We will continue to go on. And what we have to do is open up the dialogue. And we have to love on our birth families. We have to love on our birth families. And we do in our family. And my friends who have adopted kids, they love on their birth families. Right? And we put out that message loud. Parenting's hard enough. You don't need any shame. You don't need any blame. We've all screwed up. Pick up your socks, keep walking. Right? So I guess that's my message.
Cool. Lisa, I know there's been so much you wanted to talk about tonight. And again, barely scratched the surface, but how would you like to end things?
I think Jackie knows what I'm going to say, but we need everybody in this audience to join Team HOW. And last time Jackie and I were together, I'm getting buttons done up, but they're not done yet. What that means, though, is that for years we have said that the tagline or the elevator pitch that it's not about won't, it's about can't. Because we needed our community to understand these brain-based differences. But we are now ready for the next shift. And this was kind of driven home for me by one of the staff in the McDaniel Youth Program, Adrian. I doubt he's here, but he said in a staff meeting, "It is not my job to tell a youth with FASD he can't get his license. It is my job to figure out how to support him so he can do that safely and successfully." And that's kind of the mentality we need our entire community to take to support children, youth, adults, and families who are impacted by FASD.
Wow. Okay, last word goes to you.
How do you say anything on top of that?
Yeah.
First of all, I want to say that if I got hugged by the greeter going into Walmart, I would feel great. And that is a really important thing, because some things don't go that well. And when all you get is a little act of kindness from somebody, you feel fantastic. You don't got to go to university to make a contribution in this world and to have a powerful impact on the lives of everyone around you. So I think building on what Lisa and everybody else has said, we all have a role and a responsibility to our community. I think if we can be at a session like this, a meeting like this, and walk away and say, what is my role today? And what am I doing to contribute to these outcomes for this population? Because this is my community and my world as well. So I have a responsibility to support the needs of everybody in my community, not just those for whom it's easy. So let's do the how and let's find our roles.
Wow. This FASD is a real passion of the CASA CEO, Denise Mill, and so she's going to close things off. In the meantime, I would like to say thank you very much to this amazing panel. Wow, this has been a great conversation. Thank you so much for everything you've contributed tonight and on this.
On behalf of CASA and our organizations, we have a small gift. I can't figure out where it is, but I know Amanda's going to come up with it. And for the audience information, it's a talking bowl. We do want to keep the conversation going on children's mental health. Everybody, Lisa, Robbie, Jackie, Meg, and Leslie, of course. Thank you very, very much. We will be taking a bit of a break from the community lecture series. We will be starting up in September. We're hoping to bring in people like Dr. Gabor Mate, Dr. Jean Clinton, who specializes in infant preschool services. So we are setting that all up. We hope to have this as our home, because we think this is quite good with parking and location. Please fill out your feedback forms, the evaluations. That's critical to us. It helps build our agenda for our keynotes and our panel speakers. And have a great evening. Thank you so much for attending.